This week on the BackTable podcast.
Yeah. So as an interventionalist, I think you know what works for you. You have your recipe, to make the omelet. And I think you learn over time what works and what doesn't work. And you know how to keep things safe. And everybody goes through that process. So the fellows that might be listening to this podcast, I will tell you, not everything you learn in fellowship is what you're going to do when you finally get out in practice. Definitely learn what to do, but also learn what not to do. Learn from the mistakes. And you're going to make plenty of them. And even today, I still do. So every day is a school day here in Austin. So we're definitely not done with learning at this point.
Hello, everyone, and welcome to the BackTable podcast, your source for all things endovascular and more. You can find all previous episodes of our podcast on any platform or our website, BackTable.com. You can find us on socials like Twitter, Instagram, or LinkedIn, and keep up with the latest updates. And please give us feedback through comments. We love hearing from you. This discussion is supported by Shockwave Medical, developer of intravascular lithotripsy, or IVL, which uses sonic pressure waves to fracture superficial and deep cardiovascular calcium. IVL is delivered on a low-pressure PTA platform and is indicated for a broad range of interventions from the iliac arteries to the pedal arch, including calcified iliofemoral vessels to facilitate large bore access. Across multiple studies and vessel beds, IVL's intuitive platform and unique mechanism has demonstrated results that are predictably safe, distinctively intuitive, and consistently effective. Learn more at shockwavemedical.com. I'm Sabeen Dhand, an IR from LA, and I'd like to welcome Dr. Mazin Foteh from Cardiothoracic and Vascular Surgeons in Austin, Texas. Welcome, Mazin.
Sabeen, thank you for having me this afternoon. I'm glad to be here, and I'm very excited to talk about this exciting new space in, the arterial system that has always sort of been off limits to us. And hopefully we can dive deep into the topic and talk about some new technologies that we're getting to use in that space. But I'm just so excited to be here today.
Yeah, no, thank you. Thank you so much for taking the time. I mean, honestly, we're going to be talking about standard and non-standard approaches to common femoral disease. And, it was important to me and it was important to us to select someone who's well-versed in both, both open and endo, because someone talking who only does endo or someone only who does open, it's inherently going to be really, really biased. And I'm super excited to pick your brain and really kind of know the benefits of both and kind of see where things are going in the future.
Absolutely.
So tell us a little bit more about, were you always in Austin? What made you go over there to an awesome city?
Yeah. So I did my fellowship training at UT Southwestern in Dallas. I actually did my general surgery residency there as well, and then stayed on for vascular. So in total, I guess I was there for 7 years.
You grow up in Texas?
Yeah, I grew up in Texas, grew up in Houston, actually. And all my family still lives there. Interestingly enough, I'm the only person in my family who doesn't live in Houston. Oh,
really? Yeah. You made the trek out to Austin.
Yeah, but Austin's kind of like a suburb of Houston at this point. But to your point, it's a great city. And I wasn't particularly looking for Austin when we're searching for jobs, but I got a phone call one day from one of the partners in the group. They actually called my program director, and they were looking for somebody. And I was fortunate enough to train at Southwestern, where we had two really aggressive endo guys, Carlos Timuron and Frank Arco. And I learned so much from them, and they were actually looking for somebody who had a lot of endovascular experience. So I came down here after a difficult case, actually, and interviewed, and it was great. And I've been here now 10 years. And so I'm tickled to as can be. This has been a great job for me, and I have the greatest partners, and I feel one of the best cities in the United States to work in. So I'm very happy.
It's always, if you look at like the best cities to live in, Austin's always, number one or within the top three when they talk about the U.S. So that's great. How's your practice organized? You guys have both, it says, cardiothoracic surgeons and vascular surgeons, any cardiologists or?
I wish. All I can say is I wish. So it's actually, when I joined, we were 16 surgeons, and
16.
It was
wow.
16. Yeah. And 10 years later, we're 27.
That's great.
Yeah, it's a lot. So we're 12 cardiac, 13 vascular, and we have 2 general thoracic surgeons.
Wow.
But really what I've learned along the way is having this multimodality specialty practice it's really been great. Not just for me in terms of being exposed to the cardiac side or the thoracic side of things, but just being able to interact with your partners, on a day in and day out basis, and team up on very complicated cases. And it's just been wonderful, sort of alluding to that idea of having cardiologist or an interventional radiologist or even a vascular medicine doctor or podiatrist in our group. I mean, I wish we were that far out where we could, hire our own cardiologist to be a part of our practice. I think that would be the one way for us to really, have us just a destination center, really, where a patient could get all aspects of a vascular care under one roof. And you never know, maybe one day that will happen. But it's just been a great place, and I really do love being here.
Do you guys associate with a lot of hospitals, or 20 plus surgeons is a lot. So
yeah.
Is it a big surgical center, or how does it work?
Yeah. So we are a private practice, and we work in both hospital systems here in Austin. One is an Ascension system, and the other is HCA. We work in basically 3 settings, in hospital, inpatient hospital, outpatient hospital, and then we have OBLs is where we do cases. All of us sort of rotate through all the different hospitals here. Right now we're covering 9 facilities. So wow. It's very, very busy, but luckily we have great partnerships with the hospitals. We get along very well. I think we get along pretty well with all the subspecialties also. And, there's no turf wars. There's no turf wars, which I think is unique about this city.
Yeah.
We don't go after other subspecialties who do peripheral work where, I've heard of that happening in other locations.
Yeah.
We tend to be pretty friendly, and we all have complications. And sometimes, Sabeen, sometimes I'm going to need your help, and sometimes you're going to need my help. And
it always goes both ways. Yeah.
It always goes both ways. And behind closed doors, you'll probably complain about it. But when it comes down to patient care, at the end of the day, you just got to take care of the patients.
Totally.
So we've really taken that approach, and it's been fortunate for us, I would say.
Yeah, no, that's really great. I mean, you obviously have such a big vascular practice. How much is it, would you say, broken down by open or endo? You personally?
Yeah. So I've been in a transition since I've been here. When I came in, I was the new guy, and the new guy is always sort of doing the most minimally invasive thing that you can do. And that was endo. And quite honestly, at one point in my practice, I was probably 90% endo. That was in all aspects. That included the aortic disease, carotids, peripheral vascular work. And then you learn over time what really works where. And I would say today that has shifted to where I'm probably still about 70% endo, and 30% of my cases get done endovascularly. Or some hybrid. Sorry, I should say hybrid. That again.
Yeah. So 70 endo,
30 open, and then there's some hybrid work that gets done as well. But you just learn. You just learn what's going to work where, and you have to be adept in both areas, and that way we get to tailor care, and I really enjoy doing that.
What's awesome is, like you said, you tag team cases and you learn. I mean, the thing is you learn after training. I'm lucky to be within, some awesome IRs and vascular surgeons here. And I learned so much, even now, 7 years after, I've been done with training. So, you've learned probably plenty of things on the job.
Oh, absolutely. I used to sort of giggle a little bit when one of my mentors would say, how I got so good at endo? And I said, no. He said, I used to actually go in and sit in the cardiology cath lab and watch them do STEMIs. And I was like, no way. I mean, 'cause this guy had, an ego beyond egos. And truth be told, at the VA when I was in Dallas, I did a little of that as well. There was 2 cardiologists there. You probably know one of them, Berlakis, and who's great. And his senior partner, and I forget his name, we actually paired up on some studies after I got out of fellowship, but they were just fantastic. And I learned micro wire and micro catheter skills watching those guys. Yeah. So it was great. And I encourage anybody who's listening to this podcast, don't think you know everything, because you don't. You just don't. And there's so much to be learned from IR. There's so much to be learned from cardiology. There's so much to be learned from neurointerventional. And take the time to sit back and watch when you have some downtime, because it could help you one day.
Yeah. Words of wisdom. Wisdom. So let's talk about our topic. Let's get at it. Acute common femoral disease, we're not even going to talk about. We know, all of us have been there, closure device injury or some iatrogenic injury. That's surgical. And as far as the technique, we'll cover, but we're going to be talking about chronic disease. What type of patients, Mazin, do you see get pretty bad chronic common femoral disease? Is it the diabetics? Are it the smokers? Is there any type of pattern?
Yeah, I think there are some patterns here. And let's take out of the picture the folks who have had multiple access, points in their common femoral arteries. And let's just focus on primary, atherosclerosis and who presents with common femoral disease. And truly, it's smokers. Those are the folks who are going to get aortoiliac occlusive disease and common femoral disease. And on occasion, you might encounter your diabetics or your end-stage renal patients who have some common femoral disease. But in general, those folks are going to be free from atherosclerotic plaque and the common femoral distribution. So it's usually younger patients. It's usually heavy smokers. And they typically get dense calcific disease in the common femoral artery. And those are the folks that we are commonly approaching.
Okay. Yeah, I guess that's what I was going to ask you. What's the morphology? Is it usually calcified? Is it atheromatous? I mean, what do you most commonly encounter in these smokers?
Yeah, so generally less atheromatous and more calcified, sort of homogenous plaque or heterogeneous plaque in the common femoral artery. And typically speaking, when you open these vessels up to do an endarterectomy, you're not going to see the cauliflower appearance of, dense calcified disease. It's usually layers and layers of calcium and lipid deposits and platelet deposits encased in a fibrin sheath. And over time, as that lipid deposit and platelet deposit increases, luminal patency and luminal diameter tends to decrease over time. And so when we do endarterectomies, when it's completed, we have this nice, sort of 5 to 6 centimeter long lesion. And if you turned it on end and looked straight down the center, you got 1 to 2 millimeters of flow, typically speaking.
Yeah.
And so removing it, particularly in young patients, works really well. And as you know, the beauty of that is that's a pretty durable operation. Thinking back in the last 10 years, I actually can't think of a patient where I've had to go back and do a repeat intervention on a common femoral for a young patient, as long as it was done well. I know it does happen, but nothing directly comes to mind. But to get back to your question, it's just a different animal. It's not like what you see in tibial disease, and it's certainly not what you see in the SFA. It's just a completely different animal.
Yeah. No, I mean, I'm always amazed. We're so used to, as for endovascular guys, we're so used to seeing what it looks like on ultrasound or maybe IVUS or CT. And I always get amazed. Just this last week, we did a, cut down approach for an EVAR with our vascular surgeon, and the common femorals were just so jacked. But it was just so amazing to see what the artery, it looked like an artery. It looked a little regular, and you touch it and it just feels, it doesn't feel like a rock, but it just feels like this really kind of just firm kind of vessel that's just not normal.
Yeah.
And it's amazing to see it physically. It's way different than what you'd expect.
Absolutely. And unfortunately, I think ultrasounds and CT scans sometimes are just really great suggestions. You know, to your point, I was doing a case yesterday, actually, an EVAR on a patient, and we did it percutaneously. And, you know, I was a little bit worried about the right side. So before continuing with the EVAR, I went up and over and took some pictures, and I found a big 90% stenosis below my access point. You know, so I did all the right things, and, you know, I went ahead and crossed it from the other side. I removed my sheath. I ballooned it. I took a picture after the sheath went back in, and it looked beautiful. And despite all that, at the end of the case, no flow, no flow. And the only, interestingly, when I do my EVARs, I always do them with SSEP. And within minutes of pulling the sheath, the tech reached out and said, "Hey, Dr. Foteh, I'm losing signals here." And so I immediately cut down, and God, it was just such a horrible vessel that you would have never appreciated on CT or ultrasound. Yeah. So it can definitely hide some snake within those thick walls. Yeah.
Yeah. You know, now there's something we would do. We'd almost see like drive-by common femoral disease, meaning, you know, the patient has multi-station disease, SFA disease, tibial disease. There's common femoral disease. And a lot of times we kind of just pass by it, endovascular, and treat the SFA and tibial. And we kind of just see, okay, let's see if we even have to treat the CFA disease. So the question I'm getting here is, when do you have to treat common femoral disease? Because sometimes you treat all that and the patient gets better.
Yeah, no, I've been there too myself. And oftentimes, for instance, if you have a tight iliac or a SFA occlusion, and even in the setting of common femoral disease, and you leave the common femoral alone, most people are going to be fine. I think where it's really critical for us to treat the common femoral are several scenarios, and these are the ones that are coming immediately to mind. But if at any point the profunda femoris artery is going to be compromised, or is prone to being compromised because the common femoral disease is so significant, to me, it oftentimes, you know, means I should preemptively try to treat that common femoral. If there is a bypass graft below the common femoral that is necessitating inflow, that's somebody I think that should be treated. If there's an SFA stent that you're worried potentially has the ability to go down if you don't treat it, I would definitely think about doing it as well. And then on the flip side, in the superior disease, if you do stent the iliacs, or if you balloon the external, but you leave a 90% common femoral stenosis, I mean, that's not going to do anybody any good. So it tends to be an underappreciated artery. There have been many scenarios where the operation I will offer is just a common femoral artery endarterectomy in somebody who has multi-level disease. And more often than not, especially for claudicants, that's what gets them better. And you don't have to treat the SFA, and you don't have to treat the tibials, and they can go on and have productive lives. So it's just something you should really focus on and take some time appreciating. You know, now everybody's trying to switch their access points, going to tibial, going to radial, forgetting about the common femoral artery. And, you know, there's this saying, I think it was Julius Caesar or one of those Roman kings, or that don't forget your dying king. And the truth is, the common femoral artery, I mean, we should respect it. We've been using it for such a long time, and we shouldn't let it go by the wayside. But we also need to understand you can't leave a lot of bad disease in there. It's going to portend a bad outcome.
Yeah, exactly. Yeah. So, you know, the endarterectomy, the surgical approach to common femoral disease, I mean, you've already mentioned that durability. I mean, it's by far very durable. I mean, what are things, I know it hasn't happened to you, but what are things that do make it, you know, you have a recurrent disease in the patch or whatnot? What are some things that can cause that?
Yeah, so there's a number of things. One thing you mentioned is the patch, right? So there are still people out there who don't patch common femorals after doing endarterectomy. It's similar to doing CEA. There's still people out there who just do endarterectomy and then primarily close the carotid artery. So if you don't patch it, I think that puts you at risk for restenosis. There's also a subset of patients who I think have inflammatory atherosclerotic disease. And those folks, they tend to scar no matter what you do. And despite doing a clean endarterectomy and not
They'll
leaving,
scar.
they'll scar down and you'll be back. And then I think the other thing is when you're doing your endarterectomy, it's important to leave some of the media behind when you're getting into the layers to remove the plaque. If you take it all the way down to the adventitia and you remove all of the media, I think that leaves a very, very hyperplastic tissue bed and puts you at risk for restenosis. So it's important to make sure you stay in the right tissue planes as well.
How hard is that to do? I mean, to separate when you're there, the intima versus media versus adventitia. Are you able to actually tell the different layers?
Generally, yes. Generally, you're able to get into a well-defined plane, and it works out well for you to be able to do that. But there are scenarios where the disease is so bad, or it's exophytic, calcium that embeds itself even into the adventitia, that you just simply can't make a good tissue plane. And those are the folks that I think that you end up, instead of patching, you end up doing iliofemoral bypasses as opposed to doing endarterectomies. But it's an operation, I think, that doesn't get a lot of credit. People think it's just so easy to do, and the recovery is so easy. But I think we also underestimate the complications that occur with that surgery. There was a huge NISQIP, paper that came out back in 2008 looking at 75,000 endarterectomies that were done over a 10-year period. And, the readmission rate for that procedure was 15%. The complication rates were as high as 20 to 30%. And typically speaking, I mean, these patients, pretty routinely will come back either with lymphoceles, they'll come back with groin incisions that are broken down, they'll come back with hematomas, chronic pain, and readmissions to the hospital.
That benign. It's not completely, benign.
No, not by any means. In fact, that paper actually, that population did have a mortality rate, a perioperative mortality rate of about 1% to 2%. So, although rare, it's not without its complications.
Yeah, absolutely. I mean, 75,000 is a big number, so you're going to find stuff. But it's important to know that these type of procedures that they're not as easy as sometimes some people may say they are.
Yeah.
What about in your technique? I mean, we won't go in all techniques of what do you exactly do, but do you do anything other differently? You mentioned that you patch all of yours and you go to the media, but anything else you particularly do that makes your endarterectomy approach pretty successful?
Yeah. So first off, you're going to run into surgeons out there who like to either do a longitudinal incision versus a medial groin crease incision. And really, for an endarterectomy, I think a medial groin incision doesn't really allow you to expose everything very nicely. So I always do it longitudinally. I always go out very far on the secondary and tertiary branches of the profunda femoris.
Okay.
I always go about 3 or 4 centimeters into the SFA with my endarterectomy, and I never leave anything behind in the external iliac. In fact, if I'm not able to reach it from my surgical approach, that patient more often than not is going to get an external iliac stent just to ensure I leave no disease behind. But sort of taking that extra time and ensuring that 3 to 4 centimeters proximal and 3 to 4 centimeters distal to your common femoral, the arteries are nice and clean, you're not leaving dissection planes behind, is key to really having a great outcome for those folks.
Yeah, I mean, I can see now why you have such a good endarterectomy result, because you're definitely putting more into it than I've seen, doing the proximal 3 cm of SFA. That's a lot more dissection. I mean, I've been there in these cases where our vascular surgeon is dissecting, and yeah, if you can do a lot more, but it takes a lot more time. So
definitely,
dissecting 3 branches of the profunda, that's a lot,
It gets to be a lot. It gets to be a lot. But truthfully, even if you have to use two patches and sew them together, it's the right thing to do. And it improves outcomes, and the patients will love you for it, is what I can tell you.
Now, there's a lot of people who, I'm sure you do most of these under general anesthesia. I mean, there are sometimes we see some claims as far as like, oh, these procedures can be done under local or whatnot. Is that a common occurrence? Some, doing it under local, or is it pretty much always under heavy sedation, MAC or general?
Yeah, I think it's definitely something that gets talked about, doing it under less severe anesthesia is what I would say. In the 10 years that I've been in this practice, in my fellowship, in my general surgery training, I never saw a common femoral endarterectomy get done under local.
Yeah.
The closest thing to a less than general anesthesia was a couple of MAC cases where the patient got an LMA. But for the most part, I mean, these can be fraught with complications too. Sometimes getting control can be very difficult, and sometimes there's a significant amount of blood loss. I think it's a nice academic discussion to talk about doing under local, but when the rubber hits the road, very few of these cases actually get done under local.
Yeah, you need them. You need them to be asleep. I mean, and I'm actually very impressed with anesthesiologists. They can put anyone to sleep. I mean, the whole thing
These
about
days,
this. Yeah, I mean, they're so good. I mean, the patient can have a EF of 15, and they're like, okay, it's fine. We'll handle it.
Yeah, yeah. They make our lives really, really easy. And to your point, even folks with horrible COPD and on home oxygen, I mean, these anesthesiologists these days do such a good job, and mine have been excellent. That I feel comfortable putting most people to sleep.
Yeah, exactly. Yeah. Your anesthesiologist is so used to your vasculopath patients that, cardiac and all this other stuff is easy chip shots for them. So it's lucky we have anesthesiologists like this. And so when I see that argument of online on social media, sometimes like a endovascular person might say, oh, we did it this way because the patient couldn't tolerate anesthesia. I'm like, maybe shop around for some anesthesiologists and do what's best for the patient, whether it's open or surgical. And on that, so let's switch gears and talk about the endo approach. I mean, should we stop now? Is there validity to endovascular approach to CFA disease? Should we stop, or do you think there's validity in that?
No. So first of all, this is a topic that's very important to me. I know it's a topic that's very important to you. And the common femoral artery has sort of always been the no man's zone for endovascular intervention. And we've, over the years, have tried everything from cryoplasty to atherectomy to drug-coated balloons to stenting, you name it, we've tried it. And of late, and I know we're going to get into it, but lithotripsy as well. And to date, there really hasn't been a great, useful tool to address calcific disease. Not one that can really affect the entire calcific lesion. Now, some of the atherectomy devices out there have the ability to get into the intimal calcium. Some can even cause microfracturation in the medial layer, but none of them have the ability to get into the deeper layers of the calcium 4 and even 6 millimeters deep in order to have a great effect on the vessel. And so, prior to the last couple of years, I think you included just have been a little bit disappointed with the outcomes from common femoral and intervention. And so we didn't do it for a long time. And today, though, I think the tide is shifting. I think we now have some tools out there that seem to be much more effective for that particular artery and are performing much better over time. And I think the avenue for endovascular approaches are getting better. Some things that I think have improved as well is, having different alternative access points has made it a little bit easier for us to do.
That's true. I mean, you don't have to stick the common femoral now.
You could avoid it, so it makes it a lot easier for us to be able to treat these folks. So I guess to answer your question, if you asked me 10 years ago, I would have told you absolutely not.
Yeah.
Common femoral endarterectomy is the way to go. But for the past 2 years, I think my mindset has changed a little bit.
So let's talk about there's two types of CFA chronic disease, right? Something that's still open. Like you mentioned that nasty disease with a 2 millimeter, open lumen or a total occlusion. But how about, this nasty disease? What are some of the tools now that you can use, as long as the CFA is open, to help you with this chunky calcium lipid layer, plaque?
So the tool that I've been using of late, and I know you're aware of it, is actually Shockwave lithotripsy.
Mm-hmm. Yeah.
And Shockwave has now been available in the US, I believe, close to 5 years.
Yep.
Initially, it was being used in the SFA and the tibials, and then eventually the iliacs, and now the coronary. And over time, once you start using this technology, you start to figure out places where you think it'll work really well. For instance, off label, but a great place is the carotid artery. And it just sort of works there, and you're shocked by it, but literally shocked, but definitely, we learned over time that it actually can be very beneficial in the common femoral distribution. I mean, this is a disease bed that typically is not soft plaque, that typically is dense calcified disease, and doesn't respond to our standard therapies. Doing balloon angioplasty will not work. Doing straight up drug-coated balloons in this area also will not work due to the dense calcium and the lack of penetration.
I've done that where I just do a conventional, like a POBA on a CFA, and I'm like, I didn't do any. I try to convince myself the post-angio is better. I'm like, yeah, cool,
Yeah.
But it's not. It's literally, maybe 5% better when I've used a 7 millimeter balloon, but it doesn't do anything. And it's different when you use some other devices, for example, Shockwave.
Yeah, I think Shockwave has that ability to crack the calcium, change the compliance in the vessel, and ultimately improve luminal gain, which is really what we want. And to date, I think I've used it in pretty much all applications of the common femoral. So the short eccentric lesions, the long calcified lesions, the occlusions.
Okay.
Pretty much every aspect of common femoral disease that you think you can use it in, I've done it. And so I know where it works well now, and it's a viable technology. It's one that I think in the future may actually be a go-to first for the common femoral.
Wow. No.
And lots of reasons for that too.
Now, are you using it? You mentioned it to soften the plaque. Are you using it as an adjunctive technique as far as to change the compliance and then do something else like DCB or a stent? Or are you using it solely by itself and seeing what the post result is?
Yeah, so I think there's two avenues for me, one of which is just using Shockwave alone. And then the other avenue is to use Shockwave in combination with the DCB. Today, not somebody who's going to stent a common femoral.
Okay.
Not right now. I don't think there's good enough data to support that.
You're not throwing Superas and all those,
Not yet.
Yeah.
Not yet. But, I know we're going to get into this a little bit, but that's not a part of my practice right now.
Okay.
But I tend to treat it basically two ways, as a sole therapy. And if I get a great result from that, then I'm comfortable and I leave it alone. If I get a suboptimal result, or if it's a patient who I simply never want to bring back to the operating room or cath lab, then I think it's a good idea to use an adjunctive technology like a DCB to hopefully give you more durable patency over time.
Yeah.
So that's pretty much how I approach it.
Now, in your experience, has this ever burned a bridge as far as going in surgically after you've done a therapy? Like, say it didn't work that well. Are you already prepping the groin for potentially doing an open approach, or you plan for that later? And then does it mess you up at all? Does it make it more inflammatory? Like when you postplasty a vein, then that vein becomes really crappy and you don't want to do surgery on it. Is that the same thing that happens on the common femoral?
So no, not really. So I've been asked two questions. One, does it make it worse? Do you somehow compromise what you can do down the road? And then two, does it make what you do down the road any easier? And the answer to both is no.
Yeah. Okay.
So, it definitely doesn't burn any bridges. I've never had an embolic event. I've never had an acute occlusion. I've never had anything where I felt like the lithotripsy balloon was the source of that complication. But then on the flip side, even if I were to cross and I were to treat and I were to open the vessel, when I go back to do an endarterectomy down the road, it didn't make it harder, but it also didn't help it either. I've had device reps ask, well, is the calcium softer at that point? Well, maybe, but either way.
It doesn't feel like a rock. Again, like when you go in there, you don't feel, I don't know, at least the ones I've felt, and I've felt way less than you.
Yeah.
They don't feel like, I expected when I first saw this, I expected to like feel a rock or something, but it's like, calcium is rubbery.
Well, it depends what you encounter. So I've definitely had scenarios where the artery was so rock hard, I couldn't even place clamps.
Oh, wow.
Because I couldn't occlude the vessel. And in fact, there have been scenarios where it was so densely calcified, when I placed a clamp, what happened was the calcium tore the artery through the intima into the adventitia. I mean, I've definitely had scenarios like that as well.
Yikes.
Yeah. So it could be quite a challenge, but truthfully, Sabeen, I mean, there have been many scenarios where I've done common femoral artery occlusions. I've treated it with lithotripsy. The vessel has stayed open.
Yeah.
And maybe 1 to 2 years down the road, there might be a restenosis and I have to do a common femoral endarterectomy. But then when I get him to the OR, the vessel's still open.
Yeah. Yeah.
Still open.
That's great.
I mean, to me, that's a testament to a great end result.
Without the open incision and all that, I mean, it's we're in the right
on
direction
occasion,
compared to 10 years ago.
But I mean, like on occasion, you're treating somebody for rest pain or you're treating somebody for tissue loss. And the only thing you find is a common femoral artery occlusion. And you cross that occlusion and you lithotripsy it, the vessel stays open, the patient's rest pain disappears or the gangrene heals. If they're a young patient, maybe you send them to your surgeon and say, hey, this worked. I'm worried it's not going to last a long time. Could you do a preemptive endarterectomy for you? I think that's a great scenario. I really do.
Yeah.
So I think this tool gives you the option of not having to back out either. So if you encounter that, in a tough scenario, now you at least have an option of treating somebody.
Exactly. That's true. That's good. You still can do something. And then it's really important that was one of my big questions. Do I, burn a bridge or compromise a surgery after if I'm doing something like this? And in your experience, you don't. And that's huge. I think that's a huge take home point.
Yeah. So I think that, one other point we should make from that is that, if you're an interventional radiologist or if you're a cardiologist, don't let anybody tell you that that's going to happen either.
Yeah.
I know you can remember this, 5 years ago when we started getting really aggressive with tibials, the first thing all the surgeons said was, oh, they're going to burn all of our bypass bridges.
Yes.
Yeah. We're not going to be able to do a bypass now. I mean, well, yeah, if you stent the entire vessel, you're not going to be able to do a bypass. But if you go in there and you balloon a PT or an AT, you're going to be able to bypass the patient. And truthfully, as somebody who was very aggressive, I had some of my partners tell me, when I got aggressive with tibials, well, hey, you're going to create a lot of bypasses for us. And I said, no, I don't think so. I mean, maybe you're right, but I don't think so. And luckily that hasn't been the case.
That
really has not been the case. So the same is true for the common femoral artery. You can balloon it. You can do atherectomy. You can do lithotripsy. The only thing I would say is right now, in a young patient, if you can avoid it, don't stent it. That's all I'm saying.
That's a good, because, there are people who interval and supera stents, they say, okay, you can, stent across the CFA. And I know there's data out there and whatnot, but it just does sound, one of the things I want to talk about was the profunda, right? I mean, we're talking about CFA. There's no way we can't talk about the profunda. I mean, have you had any plaque shift ever when you've post-plasty this? Have you compromised the profunda? Obviously when you stent, you're going to stent across it. So that's a big, potential issue. But any issue with your current, possible IVL, DCB approach to CFA?
So I think one thing you definitely have to be comfortable with if you're going to do common femoral disease interventionally, is you have to get comfortable with being able to protect the profunda.
Okay.
Whether that means putting a separate buddy wire in the profunda while you're doing your intervention, whether that means doing a tibial access so you can have one wire across the common femoral retrograde and one wire into the profunda antegrade, you got to protect that artery. Have I had a plaque shift myself doing lithotripsy alone? No, I haven't. But I think that's because we approach the common femoral in a stepwise manner.
Yeah.
If the plaque is completely free of the bifurcation, we don't worry. We don't individually wire each vessel. But if there was any ever a concern, we take that extra step and we just do it. And it's been great for us. And as you know, oftentimes you have to do that anyway because there's spillover disease. So the ostium of the profunda, the ostium of the SFA, truthfully, that's the common femoral artery right there. And you just have to take care of all the disease, and that means doing lithotripsy in the profunda as well as the SFA. So no, it's never happened. It is of concern, and I do think you need to be careful when you're doing these types of cases because that can happen. But to date, I think as long as you're careful, you can do it safely.
Yeah. No, that's great. And yeah, you did mention too, you haven't had an embolic event, and so you're not typically using filter devices when you're treating the CFA via an endo approach, correct?
That's correct. I mean, in the last 10 years, I've never put a filter for common femoral disease. Even in scenarios where we were doing atherectomy, we've learned so much in the last decade where I feel like, although filters are a great safety net, to me, they tend to cause more problems than actually provide any solutions.
Yeah.
And now, now like the atherectomy devices are so advanced. I mean, they're doing atherectomy and thrombectomy in combination. So these newer devices, I think, are so powerful that if any embolic debris is released, it's immediately suctioned back into the catheter system.
Yeah, and speaking of atherectomy, have you what's your experience with atherectomy at the common femoral? With devices like Hawk, if you want to go directional, or Rotarex now that's out. They obviously can't go 6 millimeters in, and you can't differentiate going to the media versus you're sticking in the Intima layer, that's for sure. But what's your experience? Do you do it at all? Are you just that's not even on your table?
Yeah, so I definitely have done it, and I think I still do it to some degree, but I think it's also important to really choose the proper device if you're going to do a common femoral. So the rotational atherectomy devices like Rotarex, which you're mentioning, unless it's an occluded common femoral, that device, quite honestly, is not going to have a major effect because it can't reach the plaque.
No.
So you're being forced to use directional atherectomy devices like Hawk, potentially Jetstream because it has, the cutting blades that can be released, and CSI, a Diamondback. I mean, I think those are probably the best options. And I've had some pretty good successes along the way. At the end of the day, it's still the important pieces are choosing the right device, choosing the right size device, and being careful not to create a problem. But while you're trying to solve this issue.
Don't embolize.
Don't embolize. Yeah, I mean, it's easy to say, right? Just don't do it, right? Of course, it never happens to me, but truth is just be careful with it. Don't put a 2.0 CSI in every single common femoral artery. Small patients use a smaller device.
No high RPM, all 10 passes.
Yeah, don't do 10 passes, and don't do these, super long 2-minute runs either. I mean, those are going to be issues that get created and probably are self-induced.
Yeah. Well, great. I mean, any kind of data or trials that right now that will kind of give us a little bit more, like elucidate more what endovascular versus open or help guide us more?
Yeah. So you had mentioned before Supera and the common femoral artery. And as you're aware, there's a European trial, SuperSurge, which is looking at Supera and the common femoral artery directly against common femoral endarterectomy. I think it's 23 sites across 3 countries in Europe. They're looking to enroll about 250 or so patients. And they're pretty far along the way, and it's going to be a head-to-head analysis of Supera versus endarterectomy. And I'm excited to see what the results of that trial are going to be.
Yeah.
What I worry, though, is that the results, at least at 1 year, are very good. And now we get this sudden shift to where everybody starts putting stents in the common femoral artery.
You're right on the money. I agree too. Yeah.
And that's probably what's going to happen if the results are really good. And then 3 years down the road, we're going to be all kicking ourselves.
Yeah.
Unfortunately, Sabeen, and I think you know this as well, to me, most of the therapies that we do best when you're doing multimodality therapy.
Yeah. Totally.
If it's SFA and you're doing atherectomy with BCB, maybe even a stent in some scenarios, that performs better than just doing POBA. And that performs better than just doing atherectomy and POBA. But no one's ever going to do those trials. No one's going to put up a head-to-head
on all those three. That's too much. Yeah,
it's too much. Yeah. So as an interventionalist, I think what works for you. You have your recipe, to make the omelet. And I think you learn over time what works and what doesn't work. And you know how to keep things safe. And everybody goes through that process. So the fellows that might be listening to this podcast, I will tell you, not everything you learn in fellowship is what you're going to do when you finally get out and practice. Definitely learn what to do, but also learn what not to do. Learn from the mistakes. And you're going to make plenty of them. And even today, I still do. So every day is a school day here in Austin. So we're definitely not done with learning at this point.
Great advice to fellows. I mean, that goes across all specialties and everything. I mean, it's true. I do plenty of stuff now that I did not do, or in fellowship, and I learn every single day. And it's really nice having mentors. You work with 20 plus surgeons that are great, and having mentors, it really, really helps. So, this was great. I think we definitely covered a lot about CFA disease. Anything else you'd like to mention before we close up?
I just want to give you major props for starting this podcast. I mean, I know how busy you are, and I've learned so much from a lot of the social media sites, but also from the medical podcasts that have been set up by, innovators like yourself. Thank you for taking the time out of your schedule to do this. We're all busy. We all have, very busy lives and very busy practices. And we don't have the time to sit there and read journal articles all day long. And we also don't have the time to reach out to colleagues all day long. And I think this has just been a wonderful experience for me. And I just want to give you a high five virtually for doing this, man.
Thanks. I mean, look, the BackTable team, Aaron, Fritz, all the hosts, our sound engineers, Karen, Caleb. It's been such an awesome experience for me personally, to be a host and just learn from people like you and really just spread the word. Because I agree. I mean, the last thing I want to do is sit and sorry, JVIR, I don't want to sit and read a journal. I got plenty of things. I'd rather listen to something or something. I've learned so much from people like you and all these topics. So thanks for the feedback. I appreciate it.
Absolutely, guys. Thank y'all so much for having me.
Thank you. Thank you so much.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabeen Dhand,
Michael Barraza,
Brian Hartley,
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Zubi Syed,
article and transcript support by Taylor Robinson,
and Delaney Aguilar.
Social media and PR by Ann Dang,
and newsletter by Lauren Fang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.